Good evening. I am Francesco Sanguiloce from Barcelona. Welcome all of you and obviously all the prominent speakers that we have this evening for this very interesting webinar that has been organized by the Imaging and the Endourology Technology section with obviously the support of the school. And I'm very pleased to, have tonight also the possibility to dig in not only just presentations and data for you, but also we'll have some of our speakers will talk about some real cases, and obviously will be plenty of opportunities for you to interact also with polls. So the next hour will be full of interaction, and we obviously want you to be part of this interaction as much as you can. And so focal therapy, we will discuss these in details in the three different aspects: the concept, what are the source of energies, the clinical criteria for inclusion and monitoring, as well as what is ongoing in terms of clinical outcomes, and trials ongoing before to go for the discussion with the clinical cases. So I will not take more time on our precious hour that we'll spend together. And it's my pleasure to introduce you the first speaker. He's co-director and co-moderator with me for this webinar. Is Professor Eric Barret for the Institut Mutualiste Montsouris from Paris. He's one of the most renowned experts in focal therapy. So please, Eric, the screen is yours. Thank you for. And Eric obviously will talk about the concept and type of focal energies. Thank you.
Thank you, Francesco. Good afternoon, everyone. Let me share my screen. So I'm glad to give a talk to you today on the concept of focal therapy on the different energy sources. So I don't have any conflict of interest to report. First question, what is focal therapy? Focal therapy is a concept that involves the ablation of the index lesion of prostate cancer, which is a lesion likely to lead to potential metastases. The ideal candidate for focal therapy is probably the patient with an intermediate risk prostate cancer, ISUP2 or ISUP3. And the objective of this treatment is to maintain the oncological benefits of an active treatment while preserving as much functional tissue as possible in order to limit the risk of side effects. So as you know, when a man is diagnosed with a prostate cancer, he faces a difficult choice. Either he has a low-risk disease and then he will be a good candidate for an active surveillance, or in all the other cases, whatever the aggressiveness of the lesion, he will undergo a radical treatment, surgery, or radiotherapy. Active surveillance has been developed in order to reduce the risk of over-treatment without compromising the cure. And the radical treatment has the aim to eradicate the cancer, but with the non-complication and side effects. So what about active surveillance? Active surveillance, is a good option for patients with a low or very low risk prostate cancer. But looking at the data from the literature, you have to know that after 10 years, half of the patients quit the active surveillance due to an upgrading of the control biopsy. So it's not a definitive strategy. It's probably like radical treatment, because I would like to remind you that after 15 years, the incidence of BCR after radical treatment ranged from 24% after radiotherapy to 30% after radical prostatectomy. So we cannot guarantee the cure after radical treatment, and we know the impact that this treatment will have on the quality of life. All the radical treatment will have an impact. And we learn from the literature that urinary incontinence and erectile dysfunction are worse after radical prostatectomy, while the radiation therapy causes more bowel dysfunction. At the end, we learned from the PROTECT study that the mortality from prostate cancer is very low, whatever the treatment assigned to a patient. However, we also learned that radical treatment, active treatment, resulted in a lower risk of disease progression. That is why we think that there are probably some indication for an alternative called focal therapy. Focal therapy has been described like around 15 years ago. We don't have enough strong data, long-term data to consider this treatment as a standard treatment. That is why the guidelines consider the focal therapy still under evaluation. And they recommend to perform this treatment within a clinical trial or within a prospective registry. Clinical trial for all the energy sources except HIFU and cryotherapy that we can perform within a prospective registry. What do we mean by focal therapy? That's the problem. That's probably the problem of focal therapy. There is no standardization. And if you look at this paper published in 2022, the author reported 6,000 people who underwent a focal treatment. They were enrolled in 72 studies and 9 different energy sources were used. So there is a considerable heterogeneity of the studies in the patient selection, energy sources used, type of ablation. There is no, as well, standardization of the template. Theoretically, the focal therapy consists in the ablation of the index lesion, including a safety margin, but some treat more extensively, and sometimes they do like a subtotal ablation, and we cannot compare the ultrafocal to the subtotal ablation, and that's something that we have to think about. The same, several energy sources have been proposed for focal treatment: brachytherapy, cryotherapy, HIFU, irreversible electroporation, laser interstitial thermal ablation, microwave, vascular targeted photodynamic therapy, radiofrequency. However, no energy sources can be recommended over others, and the selection of this energy will depend on the tumor location. This is the key point, the tumor location. The choice of this treatment modality will depend on 2 different factors. The first one is the target. We need a very well characterized target, and the location of the target must allow a complete ablation, including the safety margin. And the second point, the second factor, is the energy sources. What kind of energy sources do you have? And the other question is the intensity of that energy at the target compatible with the preservation, a good preservation of the sensitive structure around the prostate, like the nerve and the sphincteric muscle. And to use the best energy or to do the best treatment, it's very important to know the limits of each of this energy. We know, for example, that HIFU is not recommended for the apical lesion due to the risk of diffusion of the energy to the sphincteric muscle. However, it's very difficult to reach from the rectum, from the transducer, the transducer piezoelectric, the anterior part of the gland. So anterior lesions are not recommended to be treated with HIFU. Cryotherapy, not recommended for the very posterior lesion close to the nerve if the patient wants to keep his erectile function. And it doesn't work very well for the central lesion due to the presence of the warmer. Brachytherapy can be very tricky to implant the seeds at the anterior part of the lesion, and for the lesion close to the blade and neck, it will generate like some dysuria. For the IRA, it's supposed to be a non-thermal energy sources, but there is a lot of unknown around this energy. It's a good energy sources, but you have to pay attention if you want to treat very apical lesion or lesion in between the urethra and the rectum wall, because the risk of fistula does exist. So that is why we developed this approach, the a la carte approach, favoring the HIFU for the posterior or posterolateral lesion, the brachytherapy for the apical lesion, and the needle therapy for the anterior lesion, because we consider that the tumor location is probably the most important prognostic factor if you want to make focal therapy a success. So to conclude, I would say that focal therapy is a promising technique which will represent a significant progress in the prostate cancer care in patient with in selected patients with a very localized lesion, intermediate risk disease. And the choice of the energy and the patient selection are the key factor of the success of this treatment. And I will give the floor to Francesco Sandiaduce, who is urologist in Fondation Puisvert, who will explain to you how to select this patient for a success of focal therapy. Francesco.
Yes, thank you very much. There's already one question, but we will address later on. So I think thank you very much again for your presentation as usual. It is very interesting to have this webinar today, which is the eve of the Prostate Cancer Day, International Prostate Cancer Day. So it wasn't just by chance that we got this day. So it was arranged exactly for us to have this webinar on such a coincidence. So in terms of patient selection is probably the most important factor in establishing a focal therapy program. So you need to have a crystal clear which are the criteria that you need to a patient should be a candidate for such a treatment. As you can see, it's not a standardized treatment, so it's not included in the guidelines, but is an option in specific conditions, especially in intermediate risk disease. So theoretically, my presentation may end up here, but obviously there are things for which is interesting to provide more details about. So digging more in would be the ideal patients. Obviously, you shouldn't be a alternative to active surveillance. So active surveillance for very low risk or low risk prostate cancer patient should be all treated with active surveillance. And obviously, in case of a patient have fulfill the criteria of intermediate risk, should be aware that it should be a secondary option if especially they are unwilling to undertake surgery radiotherapy. At least this is what the guidelines are strongly recommending us. Overall, the clinical criteria may rely strongly on the visibility on MRI. So this would be the case of grade 1 tumor on the biopsy, because it's likely to be undergrading, or especially when the visible lesions are unifocal, with as maximum grade group as being free, and a lesion less than 1.5 centimeter. We'll talk about why. And should be at the DRE, a localized, locally confined disease with a PSA less than 20, and ideally with life expectancy of 10 years or more, but still there's no consensus on that. Well, certainly we need to also identify which are exclusion criteria. And this it comes the 15 millimeters threshold that I mentioned before, because it's actually what defines the PARADS 5. And PARADS 5 is defining exactly the lesions that are bigger than 15 millimeters, because are more likely related to a potential or aggressive disease or even extracapsular disease, so locally advanced. And also patients with multiple visible lesions might be a relative exclusion criteria is not imperative. That means especially in the hands of experienced focal therapists, still this might not be an issue. But if you're starting your program with focal therapy, these are probably patients that you may not be, you shouldn't select at first instance. More impellent, let's say, exclusion criteria are according to what is the grade of higher grade of the prostate cancer, especially grade 4 or 5, or those with indifferentiated variants like intraductal, ductal, or high volume cribriform variants. As you can see, these are the different curves that you can get in terms of chemical recurrence-free survival that are very well stratified according to the different histology that you can find. So basically, these latter cases, or patient with these components or characteristics of the biopsy shouldn't be your ideal patients. Instead, you go back to what has been or what have been the other patient selection criteria. in the former studies, I would like to provide you just what has been the criteria of the ongoing randomized trials. So these are just few of those that probably our next speaker, Professor Lance, will talk about. And but I'll just provide you a hint about what are the inclusion criteria, which are tending to be more and more homogeneously between the studies. Also relevant is that we got a huge registry that is being just set up by Eric Barrett as well. Is a registry, European registry supported by the EU Research Foundation. As you can see, age may be sometimes could be a factor, especially in terms of life expectancy. But in some cases, there's no limit in terms of recruiting patients. PSA of 20 or less, and ESO grade group 2 or 3 are the most relevant data and characteristics that are reported across these studies, as well as the clinical stage. All these patients should be preferably be treated naive, even though the indication for salvage treatment is also another indication, but probably this is for more experienced focal therapies, especially for after radical XNRB radiotherapy recurrence. In terms of exclusion criteria, it's basically every locally advanced disease, more aggressive or metastatic, and obviously you need to think about that some or all maybe energy sources might have some limitations, not only just about the lesion where it is localized, but also about technical issues that may alter the final outcome. For example, size of the prostate, distance from the rectum, or presence of electrolyte or other diseases that may contraindicate the treatment itself. In terms of monitoring, so obviously we have 3 pillars: PSA, MRI, and reclassification biopsy. PSA is usually undertaken the first year most extensively. MRI within 6 to 9 months, but anyway, at least one time within the first 12 months post-op, and then also followed by reclassification biopsy. After that is actually clinical scenario according to the physician decision. PSA overall is obviously we don't have definition of biochemical relapse based on the PSA as historically. So for example, there are no criteria that could be applied like the Astro Phoenix, and also kinetics may not apply. That in this study review you can see that it was neither reported whether there was a biochemical relapse criteria showed in different studies. And this is summarized by these consensus meetings that show that basically PSA in itself cannot be used as a clinical parameter to define whether the patient is going well or not. MRI is an essential tool. We know that we learned that from obviously the relevant early diagnosis, the stratification of the patients and selection for them. And so forth is also used as much as in active surveillance, also for the follow-up in the focal therapy. And this is a very interesting study published now a couple of years ago with the London UCLH team, defining which are the criteria should be followed up when describing the outcomes or the different sequences of the MRI, to consider whether the patient is with a good response or might actually require further investigation or even just directly a biopsy. And this, I strongly recommend to you that are starting such a program to have a look at this paper, because definitely this will be one of the key parts close to the your monitoring plan. And even though it's not very well specifying these studies, but yes, it is, for example, in the registry. In the registry, as much as I showed you before, the first MRI should be done around this time, between 3 to 9 months in the registry, and or at least within the first year. And it's based on clinical judgment afterwards. And this clinical judgment might be related on the PSA kinetics, and then prompting a reclassification biopsy within the first year and whatever would be necessary afterwards. So how we can define a failure? This is also a tricky thing. So there are different ways in which, after the treatment, by observing and the PSA, we might have, for example, persistence elevated PSA. This might be the case of a technical failure. So when, for example, we undertreated the targeted area because, for example, we didn't consider well the ablation margin, or whether, for example, we underestimated the size of the tumor, or maybe because part of the tumor is resistant to the energy source we use. Another thing is actually when we knew there was a 3+3, so such an insignificant clinical prostate cancer left in place, and this not necessarily is properly failure. So this may relate to a PSA with low elevation or fluctuation. In this case, not necessarily, so we can follow this patient as an active surveillance patient. And then there's the case of diagnostic failure. So when, for example, if we don't undertake a systematic biopsy, or when actually the systematic biopsy is unable to detect an invisible lesion, so in these cases we may have elevation of PSA, could be rapid after the treatment or after work or some time, and this might be exactly the case of 3+4 or more. They might not have been diagnosed at the baseline because not visible and not detected by the eventual systematic biopsy. And another thing is definitely when actually a new lesion appears in the prostate. We know the multifocality disease is what happens in 80% of the patients. So a patient may have a new disease appearing afterwards, after 2 or 3 years, and this might not necessarily be considered as a failure of the focal. Yes, the patient might still be suitable for a new treatment, a new focal treatment in the new lesion detected. So overall, what defines a failure? So basically, a clinical significant prostate cancer detected in the treated area, though one retreatment is considered nowadays part of the strategy, should happen less than 20% of the patients, and preferably by using a different energy source eventually, if possible. But surely is when there's the need to switch the treatment. That means treating the patient with a whole gland salvage treatment like radiotherapy or surgery, or even worse, when actually they've been observed a metastatic progression. So all of this is consistent with all these studies. This is basically the same definition that you can see in these studies, but I don't want to dig in more on these details because this is going to be what actually Professor Anna Lantz from Karolinska Institute is going to discuss and present and show you in the next presentation. Please, Anna.
Thank you so much for a very nice presentation. So I will continue here to share my screen. And I try to put on my video, but maybe you can help me there. So I will present to you the outcomes and the ongoing trials. And I'm a urologist from Sweden working at Karolinska. And these are my conflicts of interest. So the balance in treatment for prostate cancer is always between the cancer control and the functional outcomes. I did my first PhD in evaluating the new robotic technique when it came, and we did a study in Sweden comparing 4,000 men doing prostatectomy with robot and open, and we saw that there was not so much difference in the side effects. However, we saw that about 20% of men were incontinent at 1 year after surgery, and 70% had erectile dysfunction. So a lot of side effects, and this is of course the ground stone for continuing with the focal therapy and evaluating new, more gentler methods for treatment. So the functional outcomes after focal therapy have emerged over the years, and the data is there from now 10 years. And This is a late review showing the risk for incontinence is very low after focal therapy. But as previous speakers have mentioned, this is of course depending on the treatment size and patient selection. But we can see here, depending on various treatment modalities, there is a pad-free rate of about over 90% for incontinence. And as for erectile dysfunction, the risk is higher, and it's a very wide range here between the studies, but most studies are around risk of 30% of erectile dysfunction after focal therapy. Oncological outcomes after focal therapy are highly dependent on the definition, which Francesco alluded about. This is a review about 50 studies, including 4,600 patients, and most of them also were intermediate risk prostate cancer, which we now recommend to treat, and not the low risk, which was treated more in the previous area. And the results from this review shows that in the intermediate risk cases, 79% were prostate cancer free at 1 year, and at the 5-year radical and systemic treatment-free survival at 5 years were 82%. But this is also, of course, depending on who you choose to retreat and put in the robot after failure. I want to shed light on some of the important trials. This is the big HIFI trial recently published. This is a prospective non-randomized trial from 46 centers in France comparing radical prostatectomy versus HIFU. And it's 3,300 patients. And they could show that the salvage treatment-free survival at 30 months was 90% of men treated with HIFU compared to 86% of those treated with radical prostatectomy. So that shows that we treat a lot of our men after radical prostatectomy, and maybe it also shows that we might treat too many of men with the BCR after radical prostatectomy. But the rate was really low after HIFU. And as for the functional outcomes, the HIFU cases showed fewer patients had incontinence or urinary dysfunction, 29 versus 44%, and the decrease in erectile function was also lower after HIFU. The difference was 7 versus 13. I also want to discuss this point of definition of failure. I think this is something to really think about when implementing focal therapy, because people who are against focal therapy will really, this is a big problem, that we need to be homogenized and having the same definitions. And this is just a review alluding on how many different definitions there are. And you can have retreatment or you can have infield recurrence, and I think it's important in the future that we streamline these definitions to be able to compare studies against each other. Looking into focal therapy, this is a study of 71 men. I think it's nice because it shows the effect that it shows on erectile dysfunction and urinary symptom based on how much you treat on your focal therapy. So this red line is the focal therapy, and this is the hemiablation, and this is subtotal ablation. So you see that you have a fast orientation in erectile function, and that it comes back and that it gets worse the more you treat, which is also very logical. And here you can see the urinary symptoms actually stay a bit lower. Also for the failure-free survival, it's highly dependent on the risk group that you treat, which is also logical, and that you have to select your patients that you think that are curable with focal therapy. This is data from irreversible electroporation. This is data from 229 men, and they have reported many different outcomes. And we spoke earlier about the infield recurrence, which is a very strict definition and nice in my view. 7.4% had an infield recurrence, which is low. And as for the functional outcomes after this IRE series, also we see the deorientation in the early phase, but then coming back to kind of the normal or the baseline functional results. So what do we have for ongoing trials? We have a strong urge for randomized trials to be able to guide guidelines in the future. We have the big part trial from the UK, the Enforce trial from the Netherlands, the FARP trial from Norway, PRIS in Sweden, Amherit and Hyfusa from France, and the Kronos from the UK, which I think now actually have a hard time recruiting. So it's a challenge to recruit patients, and it's also a challenge to have patients that drop off on the radical on the arm with the full surgery. We also have the ongoing registers, which will be crucial also to inform our future data for focal therapy. We have the Jupiter register, which Eric Barrett is in charge of. And I encourage everyone that works with focal therapy to engage in these registers, because they will be crucial to inform the future results for focal therapy over the coming years. So the PART trial in UK is a very nice initiative, and it's a large trial, randomized 800 men across 10 hospitals in the UK, and currently they have recruited 84 men, and they intervene between focal therapy with different modalities and also radical treatment with both radiation and surgery. So this is a very promising trial, and we hope that it will give us some answers in the coming years. The FARP trial in Norway has almost finished their recruitment, but not yet published. This is an interim analysis from the AUA Congress that showed, as for the oncological efficacy, that it was actually better with the focal ablation, but that is also how you define the failure. And they had positive surgical margins as a failure here for the RAD group. But you could see that the risk for incontinence was much lower compared to 34% comparing surgery and HIFU, and also the EIF function was much less the orientation after HIFU. We are running at Karolinska the PRIS trial, which is a randomized trial between prostatectomy and IRE. We do 1 year. We do an MRI at 2 weeks after focal therapy, and an MRI at 1 year, where we also do the biopsies, which I think is essential to know how well you're performing with your focal therapy. I saw a question on that in the poll. And we are measuring urinary incontinence as a primary outcome, but also the erectile dysfunction and the treatment-free survival. So we include men with an MRI visible lesion, which must be less than 2 centimeters in one direction, with Gleason 3+4 and 4+3, and the PSA below 20, unifocal significant disease, but you can have Gleason 6 outside of the target, somewhere else in the prostate. We will just monitor it afterwards. And then for exclusion, we exclude the introductal tumors because there's worse prognosis, pacemaker, contraindications for MRI, and such on. And this is the interim analysis from this December, where we had randomized 65 out of 112. As of yesterday, we actually have now 86 men, so we have 85% of the men that we plan to get. We have some men jumping off from the prostatectomy arm, which is a problem, but now it's around 20%, we believe. We look at the residual tumors at the MRI at 2 weeks, and it showed the 15% residual tumors at 2 weeks, which is kind of like current literature, and no adverse events. So we treatment plan, we get our radiologists to contour the lesion. Here we have a ventral lesion, and we put the needles outside of the lesion with a 5 millimeter margin to make a 1 centimeter margin almost around it when it's possible. We keep away from the rectum and the sphincter and the urethra. And then we do the MRI 2 weeks, and then we can see this treatment area around the lesion. Here is a case where we do this. We treated this tumor. This was the first MRI 2 weeks, and at 1 year, I think it's very important, we do this targeted biopsies where we contour the lesion, the previous tumor, and then we do the biopsies in this area, and also systematically to see if we succeeded. And in this case, the biopsies were benign. He had a lower PSA, and his MRI at 2 years were negative, and he now has a PSA of 2.5 and baseline to 4.9. So in conclusion, I think focal therapy offers favorable functional outcomes in selected patients with localized prostate cancer. We know that the long-term oncological efficacy is under investigation, and we are dependent on the randomized trials, but also on the prospective trials and the registers that we have. The technique selection should align with the tumor characteristics, and we need to rely on the different energy sources that have different features. And until we have more robust evidence, we should do focal therapy within clinical trials. Thank you very much.
Thank you very much, Anna, for this very nice talk. We look forward to hearing the results of your study. And but now we are moving to the next speakers. Let me introduce my colleague, Lara Rodriguez-Sanchez, who is urologist in Paris at Institut Montsouris, and who will present us 2 clinical cases. So, Lara, where are you?
I think you can hear me now.
Okay. You're mute.
Am I mute?
Okay, that's fine now. Thank you.
Okay. So maybe you can help me with the video. Okay.
That's perfect.
So now we are going to start with the clinical cases. So please, if you have any questions, don't hesitate to ask us. We will be happy to answer all the questions. So let's start. Sorry, but it doesn't move on. I have an issue. Is it fine now? Okay, so we are going to start with a 60-year-old man without previous surgeries, hypertension, mild urinary symptoms. Okay, mild urinary symptoms, a mild erectile dysfunction, moderate urinary symptoms, who has been followed from 2016 to today because of an elevated PSA. Here we can see that the PSA fluctuated, and he had 2 MRIs, both of them negative. And in 2024, with a PSA of 8.13, we repeated the MRI, and here we can see the lesion. And in this MRI, we identify a 8 millimeters lesion in the right posterolateral basal mid-region of the prostate. It was classified as a Pirates 4 lesion. There were no signs of extracapsular extension and no lymph node involvement. We can see that the prostate was pretty small and the lesion was posterior. We can see it here. So we performed the transperineal biopsies, and when we look at the biopsies, we can see that we identified 2 positive biopsies, both of them isod grade group 3, corresponding to the lesion that we had seen previously on the MRI. So I would like to ask you something. Will focal therapy be a good option for this patient? No, because it's an unfavorable intermediate risk case and evidence is very scarce. And it's true that there is a non-negligible risk of underdiagnosis for this patient, or just because the lesion is very localized and small, and this patient in fact came to our institution looking for a focal treatment. If the patient is strongly in favor of a focal therapy.
Yeah, thank you, Lara. I think this is one of the very impelling questions in these cases. It would be very interesting to see, what would be the answer from the audience. Definitely, this is a case where all options actually might be in place, and I think one of the personally speaking, one of the key factors is, a good conversation with the patient, and should be very fully informed about pros and cons. But, we will see now at the end what will be the results of the poll.
Yeah, let's discuss later based on the response there.
Yeah.
I have a problem with the presentation because it doesn't move on.
Doesn't go any further.
No, it doesn't. With the poll, something happened. I'm really sorry for this, but
Okay, oh yes, it's running, perfect, yes.
So as we were facing a patient with a ISO3 prostate cancer, we performed a PSMA PET CT, and then we saw that the lesion that we identified on the MRI was also visible on the PET PSMA. So in this scenario, we discussed with the patient and a focal treatment was performed. And if we look at the follow-up, what we identified is that the PSA dropped from 8 to 4.2, then it dropped to 4. So here we observe the follow-up. The PSA drop, nowadays the PSA is of 4 nanograms milliliters. We are waiting for the MRI results, and we are going to perform the biopsies, the control biopsies. But these results regarding the PSA are very, very positive. Thank you very much.
Perfect. So very interesting case. Can we actually see the poll? So most actually, yes, I would agree with most, or yeah, with the 77% who was in support to consider this patient as a candidate for the focal, because it was a 4+3, localized and small. And maybe actually this might be a case in which by undertaking a target biopsy, we might have actually an overgrading. So necessarily this might be at the end a true 4+3. So we know that there's in small lesions, we might have upgrading in 15 to 20% because of targeting. I don't know, what do you think, Eric or Anna?
About, sorry, the control biopsies.
Yeah, no. What about the poll? The results of this poll.
The poll. Yeah. The poll for me, it's a perfect indication for a focal treatment. And I had a question for Lara. What kind of energy for you is the best energy sources for this kind of lesion? Is it HIFU, or would you recommend maybe another energy sources, because everyone doesn't have all these energy sources? What is your opinion regarding the location and the lesion?
This was a posterior lesion, so I will go for HIFU as we did. As you said, everything depends on the ability to reach the lesion and your own experience. And if you have not the energy source that should be applied for the lesion, you should not treat the patient.
And do you use the PSMA PET? I mean, currently, is it something that you expect being like the future, or what is your opinion regarding this molecular imaging?
As when we are treating patients with ISO3 prostate cancer, we are pushing the boundaries of focal therapy. I think that is a good idea to look at the PSMA with the aim of reducing of improving the diagnosis accuracy, in fact. So I think that PET PSMA can be very useful, and in fact, the primary study that has been recently published has shown that if we add PET PSMA to MRI, we can improve the sensitivity to diagnose prostate cancer. So why not? I think it would be a very good option when facing patients who would be candidates for focal therapy.
Okay, perfect. Let's move on to the next case.
There is something wrong with it. I'm really sorry. Apologize for that.
It's maybe a few seconds, but it will work. No doubt that it will work. I just have a comment regarding the control MRI. Control MRI is probably the key. It's the most important in order, probably in the future, to decide what patient will have the control biopsy. However, there is one sequence which is very important in the control MRI. It's probably the injection. And we need to have an injected sequences for the analysis of the MRI post-treatment. So this is why Francesco Giganti described this PIFAB score, which drive the answer for a potential recurrence. So if Lara has some issue, we can maybe move to Giovanni. This is your Lara?
This is mine, but I don't know.
Okay, good, perfect.
It's gonna work.
Go.
So The second clinical case is a 50-year-old man without previous surgeries who had not any problem related to erectile function, no urinary symptoms, no family history of cancer. And this patient came to our institution with a PSA of 9.5. We performed the MRI, and here we can see a very small prostate. It was an 18 grams prostate. This is important. And we identified a single lesion. It was a lesion in the 9A area, as you can see in the image. There were no signs of extracapsularization, and there were no signs of pelvic lymphadenopathy. So we performed the transrectal biopsies because some years ago we performed transrectal biopsies. Now we have a suite. And then we did systematic and targeted biopsies. Here we can see that we identified 2 positive biopsies at the level of the lesion, both of them ISUP grade group 2. So the question will be, which approach would you propose for this patient if focal therapy is considered? A transperineal approach, a transrectal approach, or a transuretral approach? Remember that it's a very small prostate and the lesion was anterior. What do you think, all of you? Would you use HIFU for this patient, taking into account that this is a very small prostate?
This is the question for the audience to address, and you know, these.
But would you take that into account or not? The prostate size.
All right. So for HIFU, you know, there are also other issues that should be considered, is whether there are some cysts or some components of the prostate, like stones, the calcification that may alter a little bit the transmission of the energy. Well, if provided this is not the case, so is for a small prostate shouldn't be an issue approaching the anterior area. But obviously, surprises may come, especially if there are these changes in the prostatic tissue. They may somehow hinder the outcome.
I think it's very important to take the prostate size into account, especially if you have larger prostates going transperineal. You need to consider that you can have a conflict with the pubis bone, and also with the smaller ones, you don't have so much space to move around in. So it's definitely something to consider. Also, postoperative, you might have a bigger risk for after the catheter removal to have a retention.
Yeah, indeed. Yeah, the thing that Lara was highlighting is that because this is exactly the ideal case, that means in a small prostate. So anyway, go ahead, Lara, please, and let us know.
This patient, in fact, was treated with HIFU in 2020. Here we can see the theoretical area of treatment with anterior lesion. And here we can see the PSA evolution. There was the PSA at the beginning. The patient was treated over here, and the PSA dropped. And then we performed the 1-year MRI, and we identified a 9 millimeters lesion that was, in fact, very, very close to the area of treatment. That was classified at that time as pirates. For nowadays, I think we should use other scoring systems as the PFAB system that has been mentioned. But in 2022, we continued using pirates, and there were no signs of extracapsular extension. So we performed the biopsies, and we identified 3 positive biopsies at the level of the lesion, but all of them were ISUP grade group 1. So we decided to follow this patient as as an active surveillance protocol. And here we can see the evolution of the PSA. It continued to rise. And in 2022, 3 years later, we decided to perform a new MRI, and we observed an enlargement of the lesion that we had seen previously. And there was an important capsular contact. That's why it was classified as a Parias 5 lesion. And here we can see the lesion. The lesion that had been treated were somewhere over here. The area of treatment was all this part of the prostate because we performed an ablation, and this is the new lesion. So we performed the biopsies, and then 2 biopsies came positive, isop grade group 2, and all the systematic biopsies were negative. So we reconsidered the clinical case, and we thought that we should try a new treatment, but in this case using cryo, because it was an anterior lesion, and it was kind of an infected recurrence, in fact. Here we can see how the needle was able to treat the anterior lesion. And here we can see all the clinical case from the very beginning. At the beginning, the PSA was high, the PSA dropped after the high food treatment, then it continued it started to rise and it continued to rise. And then we identified an infected recurrence, we performed a cryo treatment, and nowadays the PSA is around 1 nanograms milliliters without any evidence of recurrence. Thank you very much, and apologize for all the issues with the computer.
Well, this is a case I think well described. For example, the circumstance we discussed before, when, for example, there might be take into consideration whether to change the energy source. Obviously, whenever you have available multiple energy sources. And see here, we got the results of the poll and which approach will you propose for this patient. So most AS was a transperineal approach with a needle ablation, and TULSA is still under, so there are much less evidence on support of that, and then HIFU again 29%. So anyway, so this was a very interesting case. I don't know whether Eric wants to comment any further, or Anna.
No, I just want to say that for anterior lesion, HIFU doesn't work very well. It can work, but it's probably not the best energy sources to use.
I think now we should switch to the last but not least speaker, and I have the pleasure to introduce Professor Lugezzani from Humanitas Hospital from Milan. He's a member also of the section, board member. So please, Giovanni, podium is yours.
Okay. Thanks a lot, Scott. So, good evening, everyone. It's a really pleasure for me to be here. I'm Giovanni Lugezzani from Humanitas Research Hospital, as Francesco already said, and that's the first clinical case. So, we are dealing with a 60-year-old man with a family history of prostate cancer. He reports mild lower urinary tract symptoms and presents with a PSA of 8.8 nanograms per milliliter. Quite small volume prostate, 35 cc's, and a multiparametric MRI showing a PIRAS 3 lesion located in the right paramedian anterior apex of the prostate. So you can see it here. Okay, so we did a targeted prostate biopsy showing a 3+4 disease on 2 out of 3 cores with a 10% 4-component and focal cribriform architecture. And we also did a systematic biopsy, 12 cores, showing an additional 3+3 cancer in 3 cores, all on the right side. As per our internal clinical protocol, in this kind of patients, we always perform a PET PSMA that showed an intense uptake in the right apex, confirming imaging concordance between multiparametric MRI and PET PSMA. So the question now is, which of the following statements do you mostly agree with? So do you think that focal therapy is reasonable despite the anterior apical location and the presence of a focal cribriform pattern? Or would you lean toward radical treatment, surgery, or external beam radiation, considering the biopsy results and lesion characteristics?
In the meantime, while our colleagues are after these answering the question. So I was wondering whether you perform the PSMA PET for all the patient candidate for focal therapy, was just in this case because it was a cribriform variant, regardless was ISO2.
Oh, that's a very good point. Actually, it is, let's say, a part of our internal clinical trial. So we are performing multiparametric MRI and PET PSMA in every single case. I'm not saying this is 100% correct, but I think in such a case, especially talking about variants that are a little bit more aggressive, or for example, ISUP 3 cases, as we discussed previously, I think that PET PSMA is really critical, and it's actually also very nice to monitor the effectiveness of the treatment.
I don't know whether we got the poll already. Yes, wonderful. Most of patients, actually our colleagues would consider this patient for surgery or radiotherapy. So what do you think about Anna or Eric? Would you done the same, or so what was the rationale for this patient then to have these this disease treated bifocal?
For us, I think we could select this patient for focal therapy. It's a single lesion and located. I mean, it seems reasonable to treat with IRE, which is the only modality that we do currently. So I think it could be treated.
Do you have any problems or bad outcomes with cribriform tumors? Eric, especially you,
I agree with Anna, and the IRA is probably a very good indication for this kind of lesion. The problem of the cribriform cells, we don't know. We accept to enroll patients for an active surveillance, for example, for when they have like ISUP 2 with 10% of pattern form maximum. This is the guidelines. But the cribriform cells depend on the percentage of pattern 4. And probably that there are patients on the active surveillance with cribriform cell, and we don't know that because it's a new notion and it's not always described by the pathologist. So for me, it's not a contraindication, and we are study ongoing, and I hope that we will demonstrate that it's not a problem to treat, because you will destroy the cells with some energy sources, and there is no differences in between the like cribriform or not cribriform cells. So for me, it's not a contraindication.
Yeah, I agree. And I was on this conference in London recently where they do a lot of focal therapy, and they were just discussing that it's not that you also, I mean, they are very experienced and they are moving towards Gleason 8 because it's more about they say it's more about the size of the lesion and not, as you say, you can kill cells in an area.
This is not something that we can recommend here because we have to follow the guidelines, but yeah, that's true.
Yeah, I'm elaborating on maybe the future of focal therapy, and it's in their experienced hands.
So very, very nice comments. So I think Giovanni would like to also show us how the case went on, please, Giovanni.
Yes. So at the very end, I will say we stand with Eric and Anna. So we did a focal therapy of the prostate right apex using irreversible electroporation with 4 electrodes. And actually, the results were pretty good. So at 6 months follow-up, we performed micro-ultrasound showing a good answer to the treatment. And the PSA also dropped down very nicely, down to 0.2. And also clinically, the patient went pretty well. No lower urinary symptoms, no incontinence, and no erectile dysfunction, just anejaculation. And 12 months follow-up, PSA was still 0.3, and both multiparametric MRI and PET PSMA were negative. And actually, also per protocol, we do transperineal biopsy at 1 year in each case, irrespective of imaging. And you can see very well the results of the treatment and the transperineal biopsy. They show no evidence of residual disease. So we can then move forward to the second clinical case. So this is a 73 years old man with no family history of prostate cancer, but a more complex medical background, a previous sigmoidectomy, COPD, and diabetes. He had actually 2 previous MRI for elevation of PSA showing Paras 4 anterior lesion on the right side. He underwent in another center 2 previous transrectal biopsies. Again, biopsies are really critical and important for appropriate patient selection. And all these biopsies were negative, but PSA was constantly increasing up to 9.9. So we perform a new multiparametric MRI showing a 2 Pirates 4 lesion, one in the right anterior transitional zone and one in the left anterior peripheral zone. So quite a small prostate, 35 cc's, and pretty much these two lesions that were quite close one to the other. A new biopsy was performed using a transperineal approach, showing a 3+3 disease in two cores from the lesion on the right side and a 3+4 disease in two cores in the lesion from the left side with a 30% of pattern 4. So this can be considered maybe plurifocal, but still, since the disease is quite close, the lesion is quite close one to the other, low volume, ISUP 1 and 2, prostate cancer. So this patient was discussed in a multidisciplinary setting, and actually external beam radiotherapy and focal therapy with cryoablation were both considered as potential treatment. And the patient at the very end opted for cryoablation that was performed, so an anterior focal cryoablation. The PSA before treatment was 10.6, and it dropped down nicely down to 1.4. And then there was a little bit of an increase, 1.5 and 1.7. He performed a new multiparametric MRI in the follow-up that showed a disappearance of the ISUP2 lesion on the left side and a reduction in the diameter of the ISUP1 lesion on the right side. And the PSA actually was a little bit still very slowly increasing up to 2.1 nanogram per milliliter at the last follow-up. So the final question for the panel will be whether, considering the PSA kinetics and MRI results, you will still consider reclassification prostatic biopsy if you will strictly rely on PSA kinetics, slow increase, and not perform any biopsy, or if you would rely strictly on multiparametric MRI and not performing any biopsy, considering the fact that especially the ISUP2 lesion is not visible anymore.
This is a very interesting question because it is one of the key factors when you consider, the outcomes. And as we can see, there's not a strict definition, and so it's basically putting together the different data and see whether actually an active treatment is needed or not. I would consider this patient stable because in the last 2 years have been basically the PSA stable. The thing that the 3+3 lesion, even though there wasn't a rebiopsy, was not fully ablated, is not honestly causing concerns to me. But I mean, well, it is interesting to see what the poll would result in. I think it is interesting that some patients may actually would be reluctant to have a reclassification biopsy, even though this should be highly recommended. So can we have the results of the poll, please? Yeah, it's quite split decision. Well, 50% classification biopsy, correct. Other, 6 people will say continue PSA surveillance, and actually, so it's just split. So half will say reclassification biopsy, other half will say continue with PSA and MRI anyway. Interesting. So Anna, any comment on that, or Lara? That
I think the current evidence suggests that it's difficult to rely only on MRI. So my strong recommendation is to do these biopsies, and then if you find small millimeters of cancer, you can still maybe follow the patient with monitoring, but it's better to have both modalities, both biopsy and MRI, in my suggestion.
At the beginning, I would like to make a comment. At the beginning, there was someone asking if it was very difficult to start a focal therapy program. And in fact, I think that when you are going to start focal therapy, it's very useful to perform those biopsies because you have the feedback of your treatment. So I would continue performing these biopsies at and I really think that it's very important for those starting a focal therapy program. Otherwise, you don't know if the treatment was a success or not. So I will strongly recommend to perform prostate biopsies, especially during the beginning of the program.
Okay, thank you very much. It's the end of this webinar. So I would like to thank my colleagues for their active participation, and we hope that you found the webinar useful. We are available for some additional questions if you want. So you understood that focal therapy represents a good alternative to the radical treatment for patients with clinically significant lesion. However, we don't have enough data, enough long-term data in order to conclude regarding the oncological outcomes, long-term oncological outcomes of focal therapy. So I encourage you to start the program of focal therapy and to join the clinical trials or the registry. And I remind you that we are launching a registry, a European multicentric registry, which is named Jupiter. And I encourage you to enroll your patient in this kind of registry if we want that focal therapy become a part of the guidelines. So thank you very much for your attention. And we are open for questions, for email or whatever, if you need some additional information.